Excellent. That's okay. You can call me Dr. Ashby, Dr. Wolfe. I've had my patients call me Doctora Lobo because that's en español. But it's a thrill for me to be here today, and I really, on a night like tonight when we have Dr. Torrens in the audience, even though I went to Cal for my MPH, it is a thrill for me to be here and actually meet you in person because I know you by your stellar reputation. My job in the 10 minutes that I have to speak tonight before we get to our Q&A is to really provide you with an overview of some of the federal policies that are moving us from this fee-for-service, volume-driven way we're providing care to a different situation, a different paradigm, if you will, that's focused more on value. Now, CMS is a large organization. We spend about $800 billion a year paying for the health care of about 1 out of every 3 Americans. That's a lot of money and a lot of people to take care of, so much so that we have 10 regional offices that you see on this slide in order to do a lot of our implementation work. I am the Chief Medical Officer in Region 9, and in addition to seeing patients every week, I also have the privilege of traveling around our region, which is geographically diverse, includes California, Arizona, Nevada, Hawaii, and all of the Pacific territories, Guam, American Samoa, the Northern Mariana Islands, Palau, and Micronesia, the Federation of Freely Associated States. So it's a geographically variable region, ethnically diverse, multiple languages, multiple cultures, multiple ways of approaching health. And we have about 20 million Medicare, Medicaid, and CHIP beneficiaries in this region alone. So it's a pretty exciting opportunity as part of my job to come and present some of this information. Really, when you think about it, CMS is doing a great deal of work right now in essentially helping redesign the way that we pay for care. With the Affordable Care Act, that was really the authority of Congress telling us that we need to really redesign some of the ways that we've been doing business in order to really truly achieve the triple aim, providing better quality care with a smarter spend of our resources, making sure that the right monies are being directed to the right kinds of care in the most appropriate way, ultimately trying to achieve a healthier population. And we have been doing that under our authority with the Affordable Care Act, really focusing mostly on incentives. How do we tie a code for services rendered to an assessment of quality, such that it's not just about knowing that you saw a patient for low back pain, but it's knowing that you provided the right kind of care for that person, be it recommendations for physical therapy, NSAIDs, and ice or heat, or someone who actually truly needed that MRI to further evaluate. And where is that? How do we pay in order to incentivize the right kinds of care? We've also been dabbling under the Affordable Care Act in testing new models of care delivery. Is it the best way to simply have one organization in a silo and then transferring off to another organization to take care of some post-acute or rehab? Or is there a better way to do it through a more coordinated system? And that's where our Center for Medicare and Medicaid Innovation has really been doing a lot of its interesting work. But under this new legislation, MacRA, we have much more work to do, because the reality is that right now things aren't as ideal as we'd like them to. There's a lot of administrative burden in the system, and despite our best efforts to promote information sharing, the reality is that none of our EMRs talk to one another, and a lot of them were built in order to support the work of billers as opposed to supporting the work of the clinical care team. So MacRA affords us a really unique opportunity, but as change is always a little scary, I'm hoping to provide you at least a basic overview, and then my fellow panelists are really going to help us dig into the weeds. MacRA is the Medicare Access and CHIP Reauthorization Act, which was passed overwhelmingly with bipartisan support last April. Essentially, this legislation builds on a lot of the successes and some of the challenges of the Affordable Care Act that we've seen over the last 5 years. Now, the information that we talk about tonight is actually directly from the law, because CMS has not yet issued a regulation on this law. It's taken us about 10 months to chew through all the different pieces of this legislation in order to ensure that our first regulation gets it right. What does MacRA do? Essentially, it is one step further in moving our health system towards paying for value, a more value-based approach, linking a fee-for-service payment or a payment simply for providing a service to an assessment of the quality of that service. MacRA also repealed the sustainable growth rate, which is that pesky formula that always we clinicians were very nervous about at the end of the year. Would our reimbursement rates be cut because Congress was going to implement this antiquated calculation? So that is gone now. We never have to worry about that again. But MacRA also fundamentally will change the way that we pay for services under Part B, which is the outpatient fee-for-service driven part of Medicare. MacRA also allows CMS to streamline our programs, which is an opportunity we haven't had before. And there are also incentives in this law to help clinicians move into what we call alternate payment models, things like accountable care organizations, patient-centered medical homes, and similar kinds of models which really focus on coordination and communication for the care of certain people. This is the world as it exists today under Medicare Part B, where a physician or another clinician sees a patient, services are provided, we send off codes to Medicare, we make a few adjustments, and then boom, there's a payment. And those adjustments are dependent on 3 different systems. Your quality of care under the physician quality reporting system, an assessment of whether or not that quality truly is adequate under the value-based modifier program, and then the effective use of medical information technology such as an EHR through our Meaningful Use program. 3 different programs, 3 different sets of quality measures, 3 different laws that govern the implementation of those programs. It's a lot to deal with, and it's a lot for clinicians. Too much, in fact. MacRA allows us to change that into a new program that allows us to assess quality and assess resource use and clinical practice improvement, as well as the use of technology, but just with one single adjustment based on performance. So in order to bill Medicare Part B, starting in 2019, you must participate in this new system, which is called MIPS. Now, there are a variety of ways that MacRA will change Medicare Part B and allow for an assessment of clinical quality. And we don't have time right now to dig into the details, and part of the reason for that is that we haven't issued a regulation on how it's going to work. But that is coming in 1 to 2 months. This spring, we will be issuing regulations around what this merit-based incentive payment system, or MIPS, actually will look like. And then, for those of us who are actually billing Medicare Part B under an organization like an accountable care organization, a patient-centered medical home, or we're doing some kind of work in that kind of a situation, there will actually be incentives to keep doing that work and even to do more work under those kinds of alternate models, such that for certain clinicians, which is represented on the rightmost part of the slide, if you're truly involved in what we call an eligible alternative payment model, a truly highly coordinated ACO, for example, you potentially can get bonuses for doing that work in that way. One of the interesting things that we know about how things look today is that about 16% of clinicians nationally are currently involved in alternate payment models like ACOs or patient-centered medical homes. And MacRA allows us to help clinicians to do more of that work by bringing more clinicians up to speed in terms of truly transforming clinical practice. That's what the Transforming Clinical Practice Initiative is all about. And we actually have organizations here in the LA area who have contracted with us at CMS in order to help bring clinicians who maybe not have implemented an EMR or are just struggling with workflows. No matter what your size or your mode of practice is, this initiative essentially is free technical support. The timeline for the implementation of MIPS and alternate payment systems is one that depends on kind of where you fall and what kind of clinician you are. But essentially, the MIPS system will be in place in 2019. And in addition, payments and bonus payments for participating in alternative payment models will also begin in 2019. Now, it's hard to do this work and measure what's happening if you have a variety of quality measures. And part of CMS's work to date, actually in February, is that we have coordinated with commercial payers, Medicare Advantage payers, Medicaid, and clinician organizations to develop core measure sets such that a clinician in any of these particular specialties can send this information to Medicare, to Blue Shield, to Medicaid, and the like, such that we're all using the same set of quality measures, which is a big step in a direction that we're going in terms of aligning the incentives and aligning the system so we're all getting the same information. We're also highly focused on health equity, and in particular, some of our most vulnerable populations, which include sexual and gender minorities, racial and ethnic minorities, and the disabled, who represent a significant proportion of Medicare and Medicaid beneficiaries. We're also focused on the social determinants of health, and the second model here through our Innovation Center is really the first of its kind to test whether we can improve patients' health by addressing their health-related social needs. This is a model that's actually currently open for application, and if you'd like more information, there's the link for you there. I've also provided some additional information for you, and we can make these slides publicly available, but what should you do to prepare for what's coming and for some of the information that my colleagues are going to share? Look for future educational opportunities. My contact information is here, and part of what I do is explain this law in much more detail than I've done tonight. Also, think about getting involved with our Transforming Clinical Practice initiative. There's a lot of discussion going around about how to really truly build an alternative payment model and an alternative way of delivering care that we actually are allowed to therefore achieve the triple aim. With that, just keep in mind that things are changing very rapidly, and so it's very possible that next week or next month things may be out of date and there'll be a whole new set of slides for you to review. So with that, thank you very much for having me, and you're always more than welcome to contact me.